I'm going to discuss the use of intravascular ultrasound in dialysis access assessment. These are my disclosures. So we know that a proportion of patients who have hemodialysis access will develop thoracic central venous obstruction, and this will manifest as swelling involving the arm, the neck, the face, and chest, and present with prominent and distended veins in the chest and shoulder. And this can result in access dysfunction or failure, and in extreme cases cause respiratory distress. And the etiology, as we all know, is multifactorial, contributed by their renal failure, causing a pro-inflammatory state. The altered hemodynamics from the AV access contributes to the development of stenosis. And often these patients may well have had central vein catheters placed and/or other devices. And the difficulty in assessment of the central veins is due to a number of structural factors that we all know, which makes assessment with ultrasound difficult in these locations. At the thoracic inlet, there are three distinct areas: the retropectoral space behind the pect minor muscle, the costoclavicular space between the clavicle and the first rib, and the interscalene space here. So the assessment of the vessels need to take into account all of these anatomical factors. And this is a really nice consensus document that was published by Bart Dolmack with the consensus, which really looked at the central veins and and gave us a sort of a mind map almost to determine which vessels were involved, to determine what the treatment from there ought to be. So why do we need intravascular ultrasound? Just as a sort of a critique of the other imaging modalities that we are familiar with. We know that ultrasound is very good at assessing anything from the humerus downwards, but in the central veins it's virtually impossible to assess the veins. As we heard, cross-sectional imaging, MR venography and CT venography forms an excellent imaging modality for these anatomical locations, but CTV does carry a risk of a radiation burden. Traditional MRV techniques has involved the administration of gadolinium, so I'm really excited to hear the potential for non-contrast MR venography in this instance. And we know that digital subtraction angiography currently forms the mainstay of imaging and assessment. And so the benefits really, or the advantages of intravascular ultrasound, it is an invasive imaging modality, but it does provide exquisite cross-sectional imaging, as I'll show you in a couple of examples in a minute. It does not involve any exposure to ionizing radiation or contrast administration, and importantly, during interventional procedures can be repeated numerous times to assess adequacy of treatment. There are at least two devices out there. The one is the one by Philips, the Volcano device, and another by Boston Scientific. So there's options for devices. There are pros and cons for both, but in essence, they both provide exquisite imaging of the vein wall and surrounding structures. So really how it plays into the algorithm of the decision-making process in terms of the diagnosis, it gives us very accurate assessment of the lesion severity and importantly of the lesion extent. And when it comes to the intervention, it allows us to precisely choose the sizes of the devices that we need to use, be that a balloon or a stent, and assess following treatment, the adequacy of treatment. And I think these are really important factors which play into optimizing our outcomes from treatment. This is the typical example of a patient with a left arm fistula who has a symptomatic subclavian vein stenosis. And if we sort of eyeball this and put a 10 millimeter balloon in and inflated the balloon and got this sort of waist appearances which obliterated with a higher pressure, you'd feel quite happy about this if you only looked at the angiogram images and the flow on the right looked okay. You may be tempted to accept that as an adequate treatment. But when we put an intravascular ultrasound in and do a pullback coming down it, you quite quickly appreciate that there's a degree of stenosis or that is still remnant, which has not responded to treatment. Furthermore, in terms of the extent of the disease, beyond where the stenosis may be, in inverted commas, at the area of the lesion on the angiogram, you'll very quickly start to appreciate these post-thrombotic synechia or post-thrombotic webs, which tell us that the extent of the stenotic area is much further than what we appreciate only with angiography. And importantly, once we treat the patient, be that with angioplasty or stent placement, we're able to then assess again the treated segment, in this case a stented segment with intravascular ultrasound, which demonstrates to us that the stent is widely opened, it's well opposed to the wall, and we've covered from good vein to good vein, which are really important principles of treating adequately central vein stenosis. So if we now go back and just a couple of philosophical points to finish up on, if you look at the outcomes of treatment that's been reported in the literature with balloon angioplasty, we know that the 12-month patency is approximately 25%. Bare metal stents, we've heard, have variable results, and covered stents still at 12 months can be as low as 40%. The question to ask ourselves is, could reliance on DSA alone have contributed somewhat to these poor outcomes? So I just want to put it out there, and for sure we can debate that. And in terms of, in the future, guiding therapy, intravascular ultrasound allows us to look at the vein wall in detail. Can we start to differentiate between fibrotic lesions and neointimal hyperplasia of the central vein stenosis? And Panos and his group here have published again on the role potentially of drug-coated angioplasty in central vein thrombosis or central vein stenosis. So could this again influence the decision of what we use? But there are clearly disadvantages to consider. There is a cost element to consider. One of the IVUS catheters is a 9 French device, the other is an 8 French device, so certainly the sheath size. And for sure, there is a very shallow learning curve in terms of getting used to looking at these images and interpreting it, but I think that is really not really that much of a factor. So in conclusion, I'd like to say that intravascular ultrasound allows for accurate assessment of the severity and extent of the disease, and importantly gives us a good guide on a treatment outcome. Thank you very much.